so we're going to get started. Everyone, thank you for coming. For today's presentation, we'll be talking about the 3 Ps of pharmacy-focused extensive stage small cell lung cancer care with DLL3 targeting T-cell engagers. And it is my pleasure to be speaking with Dr. Carl Gay. He is an associate professor within the Department of Thoracic and Head and Neck Oncology at the University of Texas MD Anderson Cancer Center in Houston. And I'm Shelby Quinn. I am an oncology clinical pharmacist within the Thoracic Head and Neck Clinic at Levine Cancer in Charlotte, North Carolina. So we want to thank you for joining us today. We also want to thank PeerView for having this session and Amgen for providing the educational grant. And it's really important to complete the pre-event survey for us. And for our participants in the room, there will be a QR code on the next slide, and you can use that to get slides, answer the polls, as well as submit questions. And for our virtual audience, you'll be able to answer the polls on your screen and add questions to the chat. So here is the QR code. We also want you to know that there is an opportunity to win a gift card. So to do that, make sure you're doing the survey, answering the polls, and submitting questions to faculty. You'll also learn if you win at the end, your screen will turn green, and so just find one of us to provide you with your gift card. Here is a QR code again to get the slides for the presentation, as well as any practice aids that will be utilized and presented throughout. For the presentation today, we will be talking about the current evidence utilizing extensive stage small cell lung cancer for our DLL3 targeted T-cell engagers. We'll also talk about pharmacy-led strategies for safe and effective implementation of these therapies. And then lastly, we'll focus more on coordination of care, talking about adverse event management and prevention, as well as education engagement with patients. So we have a poll question. From your perspective, which of the following represents key challenges related to integration and use of DLL3 targeting T-cell engager therapy in small cell lung cancer? So developing and operationalizing standard protocols for safe administration and monitoring, multidisciplinary education and training, diagnosing, grading, and managing CRS and ICANS, logistical barriers to access and care transitions, ongoing doses, schedule verification, and patient-specific considerations, or all of the above. So it seems that we are all still having challenges integrating our DLL3 targeting T-cell engagers. Most people here have selected all of the above. And I'm going to hand it off to Dr. Gay.
Thank you, Shelby, for the introduction, and thank you all in attendance. So I'm going to talk a bit about the T-cell engagers themselves, some of the data in support of their use, touch on a little bit of the toxicity, and then we'll hand it back over to Shelby in a little bit to go into some of the toxicity management details with a bit more nuance. So small cell lung cancer, as likely many of you are in the room are aware, is a relatively rare type of a very common disease. Accounts for about 15% of all lung cancers in the United States, and that's a similar number worldwide. Still primarily linked to cigarette smoking use, by far and away the most significant risk factor for small cell lung cancer. We do see transformation and occasional small cell lung cancer in never smokers, but that's the exception. Been long-standing challenges in small cell lung cancer. It is getting better. Lack of targeted therapies, right? It's not an oncogenically driven disease. We don't have TKIs. These tumors develop resistance very quickly, and historically we've had very poor options for them, particularly in the relapse setting. We also face a unique challenge here where brain metastases are extremely common in small cell lung cancer, with upwards of 3/4 of these patients developing brain mets at some point during their natural history. So as I said, there's been some progress. When I first started talking about small cell lung cancer in venues like this and writing grants, I used to get to say there had been no successful clinical trials for small cell lung cancers and no approvals in over 3 decades. That has changed dramatically in the last 10 years. And so we've seen, obviously, the addition of immune checkpoint inhibitors to frontline therapy. We've also seen the approval of lurbinectedin first in the second line, now more recently in the maintenance setting alongside atezolizumab. We've seen tarlatamab approved and then more formally, fully approved this last year in the relapse setting. And we're going to focus a lot of attention on some of the data there for tarlatamab today in particular. And then coming down the pike now, we see other T-cell engagers, as well as antibody drug conjugates, radiopharmaceuticals, and so there are entire classes of drugs that no one could have imagined even 5-6 years ago in this space that are now really taking hold. So what does the treatment algorithm look like for extensive stage small cell lung cancer right now? So the historic one, just going back a couple of years, right, was first-line chemoimmunotherapy, and then second-line therapy was topotecan, lurbinectedin, or tarlatamab as of May of 2024. In the new treatment algorithm, I think solidifies particularly this relapse setting a little bit. So the first line continues to be chemoimmunotherapy. In the maintenance setting, you can now add lurbinectedin to maintenance alongside atezolizumab per the IMforte data. In the second line, I think we have a pretty clear indication for tarlatamab versus the remainder of the investigator's choice agents, which have been largely pushed to the third line if patients have not received them to date. And I think it's important to recognize that we need to use, and this is true in probably all tumors, that we need to use our best drugs earlier. And while this may change as we develop better therapies for small cell lung cancer, there has historically been a significant attrition rate as you go through each line of therapy for small cell lung cancer patients. And so each step to second line to third line, you lose about half of the patients that receive therapy in the previous line. So if you have a really good drug, you probably don't want to save it for the third line setting. You don't want to do that as a patient. You don't want to do that as a physician. You don't want to do that as the drug developer because fewer and fewer patients are going to get it. Right? And so again, I think as therapies get better, this attrition rate probably gets better, right? Patients don't fall off a cliff, but it's still important, and you'll see that strategy at play here to move things as early as possible if you have a better drug. And so let's start with a poll question. This is actually more of a pop quiz to the audience, I think, and then you'll come back to that. And so which of the following of these choices makes DLL3, delta-like ligand 3, a rational therapeutic target in small cell lung cancer? So 1, DLL3 is commonly and abnormally expressed on the surface of small cell lung cancer cells, but minimally expressed in healthy lung tissue. 2, DLL3 is most highly expressed among those small cell lung cancer subtypes with the most inflamed tumor microenvironments. 3, both of the above. Or 4, I'm not sure. Okay. So a real mix of choices here. I would say fairly close to an even split among the options. We will come back to this, and so take note of what you've answered here. So the rationale for targeting DLL3. So DLL3 is an inhibitory notch ligand that is robustly expressed in small cell lung cancer and other high-grade neuroendocrine carcinomas, as well as some other neuroendocrine neoplasms in general. It tends to be intracellular in normal cells, but gets moved to the surface in neuroendocrine carcinomas. Depending on where you look, you see somewhere in the neighborhood of 90% of small cell lung cancer tumors express DLL3. And so obviously it's a good target for that reason. It's highly expressed in the tumor. It's also important to note that it's not particularly highly expressed in other normal tissues. Some of the toxicities that are unique to tarlatamab will give you a sense of where the DLL3 is expressed in other normal tissues, such as the dysgeusia, the loss of taste that these patients experience. Seems to be an on-target, off-tumor effect. DLL3 is most highly expressed in those small cell lung cancer tumors that are immune cold. And I really can't emphasize this enough, that small cell lung cancer is an immune desert, right? 80+% of small cell lung cancer is essentially a complete absence of T cells and frankly, many immune cells at all, certainly ones that are helpful, as well as low expression of immune checkpoints. They don't need them. There are no T cells there to exhaust. And so the fact that DLL3 is expressed very highly in these less inflamed subsets, you can imagine is advantageous given the mechanism of action of T cell engagers, which we'll talk about in a moment. So by virtue of the fact that you're attending this, you probably have some sense of how T cell engagers work, but just humor me for a second here. And so you have two key components to these bispecific T cell engagers. So you have an antibody that binds to something that's unique to the tumor, and then you have an antibody that binds to something that is unique to the T cells. And so in the case of most of the drugs we're going to be talking about today, that is a CD3 binding region, and then a tumor-associated antigen binding region, in this case DLL3. And so going back to the point that small cell lung cancer is an immune desert, you can essentially force an interaction between T cells and small cell lung cancer cells that would otherwise not occur by binding T cell and the tumor and bringing them into proximity with one another. And so this forces the issue and sort of moistens an otherwise immune desert scenario, so to speak. And so, specific to the DLL3 T cell engagers, as I said, the unique element of these is that they have the antibody that binds to DLL3. And so you can see the structure of tarlatamab there. There are other DLL3 targeting T cell engagers that are not quite as far along in development. They are not all structurally similar, but they are mostly functionally similar. I will talk about one of the exceptions to that in a few slides. And so people are certainly trying to build a better mousetrap around these DLL3 T cell engagers. But I think for the purposes of our discussion today, appreciating that you have an antibody that binds DLL3, an antibody that binds CD3, and forces T cells to interact with the tumor cells is all you need to know. And so I'd like to give folks a moment to return to the prior poll. There was a lot of indecision on the poll previously. I hope I have remedied that. And so I'll give you just a minute before we go on to the next slides, just to see whether you have any better sense now of why DLL3 is being targeted in small cell lung cancer. So let's talk a little bit about the use of these DLL3 targeting T cell engagers in small cell lung cancer, as well as some of the data in favor of their use. So we'll start with a case. This is a patient named Peter who develops disease progression on first-line chemoimmunotherapy for extensive-stage small cell lung cancer. So Peter's course, newly diagnosed with extensive-stage small cell lung cancer at the time, an ECOG PS of 1. Received platinum etoposide plus durvalumab for extensive-stage small cell lung cancer, completed 4 cycles of the chemoimmunotherapy combo, and then had some delays along the way due to slow count recovery, but ultimately successfully transitioned to durvalumab maintenance. But restaging scans, as they often do after 2 cycles, showed progression of disease. It's often sort of gallows humor that the progression-free survival in most small cell trials is whenever you decide to do the first CT scan, right? And that's historically been true in these maintenance studies, unfortunately. Peter's ECOG performance status remains preserved at this point, but is not interested in pursuing a clinical trial at this point. So we're now into the second-line setting. We have relapsed small cell lung cancer, a relatively short chemotherapy-free interval if you're into that sort of thing. And so bear this case in mind as we go through. And so let's first address it with a poll question. So assuming clinical and trial enrollment is not pursued, Peter declined that, what second-line therapy would you and your multidisciplinary team recommend for this patient with extensive-stage small cell lung cancer? So you could do platinum etoposide retreatment, topotecan, lurbinectedin, tarlatamab, referral to hospice, or I'm not sure. Give folks a minute to ponder those options. And I would say answer this as if you had the opportunity to give whatever drug you would like, because I know there are some variations in the availability of these drugs from institution to institution. That's something we can talk about a little later, too. Okay, so a pretty overwhelming favorite here for tarlatamab, and I think the folks that answered that will be reasonably vindicated in the coming slides, though I think there's, historically speaking, there's not strictly perhaps a wrong answer here, but more recently, I think tarlatamab has emerged as the favorite in the relapse setting, and this study here is wise. This is the Delphi 304 study, which is a randomized controlled phase 3 study for second-line treatment of small cell lung cancer, and so these were patients that had progression on first-line chemo or chemoimmunotherapy but had retained their performance status. There were several stratification factors, as you can see there, with a primary endpoint of overall survival. And these patients were randomized 1-to-1 to receive either tarlatamab or investigator's choice of chemotherapy, topotecan, lurbinectedin, in other countries, amrubicin, which is commonly used. You can see the breakdown in the dealer's choice percentages there. And so looking at the OS Kaplan-Meier curves, you can see that there is a significant benefit to tarlatamab versus the dealer's choice chemotherapy in the second line, over 5 months improvement in median overall survival. I think a fun thing to note here is that the median overall survival in the tarlatamab group of 13.6 months is actually better than the median overall survival in either Empower 133 or Caspian, right? So this is better than the frontline survival in what had historically been our standard of care there. And so clearly a step in the right direction. And a very, very significant hazard ratio and p-value for these patients. So clearly met its primary endpoint. And this took us from a scenario where the second-line strategy in small cell lung cancer was tarlatamab or lurbinectedin or topotecan or various off-label single-agent therapies to, I think, pretty resoundingly, if you can get it, tarlatamab. If you can't get it, you should find some way to get it, right? So looking at the forest plot here, there was no clear indication that tarlatamab's benefit was preferentially seen in any particular subgroups. And I think a lot of logical subgroups in here. So patients with or without prior PD-L1 exposure both seem to benefit similarly. Looking at different chemotherapy-free intervals, there were similar benefits across the chemotherapy-free interval landscape. Presence or absence of brain metastases did not seem to have a major impact. There wasn't really anything that jumped out here. There's maybe a small number of patients that received lurbinectedin overall in the study, and the benefit was a little bit less resounding in that population, but overall, I think a pretty consistent, unanimous victory here. Looking at progression-free survival was also significantly improved. You see a much more modest improvement here, a 0.5-month improvement in progression-free survival. This is something that's we've seen in a couple of different data sets for tarlatamab where a lot of the benefit seems to show up in overall survival rather than progression-free survival. I think there are differing opinions on why this might be the case. You could have the patients who are doing well are doing really, really well, and so they're doing a lot of the heavy lifting in the Kaplan-Meier curve. Could also be that tarlatamab is fundamentally changing the tumor and making it more vulnerable to future therapies. I think these are reasonable hypotheses without clear evidence supporting one or the other here. I guess there's some statistical evidence to support the former. The durability of the responses, which is in support of that former notion that patients that do respond do quite well, is longer for tarlatamab. And I think the 6.9 versus 5.5 month comparison here probably undersells what we're seeing in the Kaplan-Meier curve there, where you can see there's quite an impressive tail with tarlatamab, where a number of the patients are progression-free at 12 months. It should be noted, though, that the data on this were relatively immature. It was such a significant overall survival benefit that the data got out to the public very quickly. And so better PFS, better duration of response, better overall survival to tarlatamab. The caveats being that it was dealer's choice in this, and it wasn't sort of equally distributed among the dealer's choice. So heavily favoring topotecan, a drug that I think a lot of us are not terribly in favor of using. The safety profile for Delphi 304 and tarlatamab versus everything else. If you look at just the rate of treatment emergent AEs, it's not all that different. Obviously, the side effect profiles are very different, and so what you're actually seeing here is sort of typical chemotherapy side effects on one side, your nauseas, your myelosuppressions, and then in the tarlatamab side, you're seeing sort of unique T-cell engager therapy-associated toxicities, such as cytokine release syndrome, ICANS, et cetera. And we'll talk more about the rates of those in the future. The rates of grade 5 treatment-related events, low in both arms, and actually relatively little treatment discontinuation, only 3% of tarlatamab patients and only 6% of the chemotherapy patients. And so it seems like the patients got a fair shot with the drugs that they were assigned to. I mentioned the unique side effect profile, and we're going to delve a lot more into this. I think that's probably the most useful thing that we can do for the audience today, is to talk more about the nuance of managing these toxicities. But what are the toxicities that we see? And so the big ones are cytokine release syndrome and then ICANS, which is a neurologic syndrome that you'll hear about a bit later. CRS is reasonably common, particularly in the first dose of tarlatamab, and to a lesser extent the day 8 dose. It is mostly low grade, as you can see here in the box plot and in the table. So very, very little grade 3 CRS that's seen, mostly low grade CRS. Sometimes still requires some management, some thinking on our part, but not something that's likely to make the patients really sick or lead to discontinuation of the drug. Just something that you need to be prepared for. And ICANS is a lot less common. It's also a little bit more nuanced measuring ICANS. ICE score is not quite as familiar to folks as, say, taking a patient's temperature post-infusion. And so I think there's a little bit more room for ambiguity in ICANS, though in the trial is pretty well controlled. As I mentioned, tarlatamab is not the only T-cell engager in town. Obrixtamig from Boehringer Ingelheim is another DLL3 T-cell engager, I think functionally very similar to tarlatamab. This drug has shown activity in not only small cell lung cancer, but other high-grade neuroendocrines. I mentioned that DLL3 is expressed across the high-grade neuroendocrine carcinoma landscape to a varying degree. So here you see in these waterfall plots pretty decent activity in extrapulmonary neuroendocrine carcinomas, as well as pulmonary large cell neuroendocrine carcinoma. These are all uniformly very difficult to treat. These other neuroendocrine carcinomas really lack any standard of care. And so a drug that's active not only in small cell, but in these, since we're often hijacking small cell standards of care for these other for these other tumors off-label, I think gives a sense of the promise of these DLL3 T-cell engagers beyond just the small cell space. And this is just showing the response data for obrixtamig, and as the dose increased, these are different escalating dose cohorts here, the response frequency was higher. And the treatment-related adverse event profile looks very similar to what we've seen with tarlatamab. So again, some CRS, some dysgeusia, some patients losing their sense of taste, fevers, fatigue, but nothing really emergent that suggests that the toxicity profile, or for that matter, the efficacy profile, I think varies greatly between tarlatamab and obrixtamig. And so obrixtamig will be assessed in the first-line setting in the ongoing DARION-8 study. And so as I mentioned before, if these drugs are truly the best that we have for small cell lung cancer, we should give them to patients earlier. I also mentioned the notion of building a better mousetrap around DLL3 T-cell engager. And so one of the ways that folks are attempting to do that is illustrated here in the drug from Zelgen, ZG006. This is a tri-specific T-cell engager, which includes biparatopic targeting of DLL3. And so you got 3 antibodies instead of 2. Still got the 1 CD3, but you now hit 2 different epitopes on DLL3. And I would say offhand that doesn't seem like that would make a great deal of difference, right? But you don't know enough about the resistance mechanisms to tarlatamab and other bispecific T-cell engagers yet to really know. And so theoretically, this could potentially hit lower expression levels of DLL3, or may also mitigate some of the resistance to DLL3. And so we have some data from 2 different dose levels in the phase 2 study with the Zelgen drug, and the objective response rate has been impressive so far. And you don't want to read too much into such small numbers, but objective response rates in excess of 60% in the 10 milligram group here. That's compared to what has pretty consistently been a 40% response rate for tarlatamab in similar groups. And so there's the potential that this could exceed what we have already with the T-cell engagers that are available or are more mature, or it could be used in cases where patients have developed resistance to those T-cell engagers. So I think it will be interesting to see how the data plays out with the trispecific T-cell engager. There are other T-cell engagers also in the mix that add a co-stimulatory component to try to ramp up the immune system. Again, we don't really understand enough about the resistance mechanism to know what to go after at this point. Is the resistance that DLL3 is being downregulated? Is the resistance that the T cells are being exhausted? Is there some combination of that? The only data we've really seen on that is data from Mass General that included like 5 patients that was recently published. So it's pretty much anybody's guess now. So, as I mentioned, I don't think anyone is satisfied to stop with tarlatamab in the relapse setting, and there's every reason to think that we should be getting this drug to patients as early as possible, given the success that we've seen so far in the third line and then second line setting. And so the phase 1 study to assess the safety of adding tarlatamab earlier is the Delphi 303 study. Here, patients would receive the standard chemoimmunotherapy, and then when they would get to the maintenance setting, tarlatamab could be added to either atezolizumab or durvalumab maintenance. This was primarily to make sure that there were no emergent adverse events when you combine this early on with an immunotherapy, but also, of course, we all want to know what did the outcome data look like. And the outcome data is pretty impressive. And so you don't want, as I mentioned before, to read too much into small numbers from early phase clinical trials. But if you're trying to estimate a median overall survival from Delphi 303, it appears to be in excess of 2 years. This is, if we think of historic controls, you're about 1 year in Empower 133 and Caspian, somewhere in the 12 to 13 month range of overall survival. If you throw IMforte into the mix, you're probably adding 3 to 4 months to that in overall survival, so maybe bumping it up to 16 months or so, 16 to 17 months. And so this seems to exceed the historic controls, but again, this was not meant to show us anything other than safety, and so we should include all the caveats that come along with early phase clinical trial data, but impressive and reason for enthusiasm nevertheless. We haven't talked about limited stage small cell lung cancer at all. Obviously, there's been a significant shift in the management of this recently as well. So there's at ASCO 2024, we saw the data from the Adriatic study with durvalumab being added to the limited stage setting with a 20-plus month improvement in overall survival. So really the first real limited stage progress we've seen in a long time, especially on the systemic therapy front. I think it's obvious to think, well, could we incorporate Tarla into the limited stage setting? So there's already a trial underway to do that, the Delphi 306 study. I think the one knock on this study, not to editorialize too much, was that it activated just before the Adriatic data, and so the control arm here is placebo rather than durvalumab. And so it'd be interesting to see what these data look like if they are if the overall survival is overwhelming, then that may be enough, but you could imagine a need to compare this to durvalumab or combine it with durvalumab in the future as well. So just to return to the case here, our friend Peter, so I think we can sort of discuss now what the best options are for this patient. I think it seemed that the room was already kind of on to what they thought the best option was, right? The poll overwhelmingly was in favor of tarlatamab, and so it didn't seem that folks needed a lot of convincing that this was now, I think, largely the inarguable standard of care in the second line setting. And I think it's important as we transition into the next phase of the presentation to really think about what our role is as the physicians, as the pharmacists, as the support team for the patients and their caregivers in making sure that patients are able to get tarlatamab, because it's something that a lot of us, speaking for myself, I had never, outside of a clinical trial, I'd never given a T-cell engager before tarlatamab was approved. Now I've had the opportunity to give this hundreds of times, at our center, but there's a bit of a learning curve to it, and there's certainly a learning curve for patients that have been exposed only to chemotherapy and immunotherapy in the past. And so we'll let everybody have a chance to answer the poll again. We won't We won't reveal those answers, but I'd be curious if anybody changed their mind after seeing that data on whether they would use tarlatamab or something else in the second-line setting. And so I'm going to pass the mic back to Shelby now, who's going to talk about the monitoring and management of adverse events in the clinical use of DLL3 targeting T-cell engagers.
So we actually have a couple questions that have come in that I think really relate well to the section you presented on. So one is, what causes immunotherapy resistance in small cell lung cancer and for the microenvironment to be more or less inflamed?
Yeah, that's a really good question. And unfortunately, the answer I think is largely we don't know. So we know that that there's about 15% of small cell lung cancers that are intrinsically inflamed. We call these inflamed, SCLC-I or SCLC inflamed, and they have interferon signaling and all the things that you'd expect to see in an inflamed tumor. And the rest of small cell lung cancer tumors have none of this. There are some data that suggests there might be sort of a physical barrier or a vascular barrier preventing T cells invading, but it's odd because small cell lung cancer has high DNA damage, a lot of DDR problems, so it should be attractive to the immune system. But we don't have a good sense of what makes it so intrinsically inert from an immunologic standpoint so far.
Yeah, and I think too, like you've mentioned, like over time, we really haven't had a ton of successes in small cell lung cancer. We're still constantly learning about the disease and how we can better treat it. And so there's still a lot of mysteries. Another question here is there any role for biomarkers, either DLL3 expression or circulating tumor cells? And then talking about kind of like exclusions, like active or symptomatic brain mets.
Yeah, so I think there's obviously will be room for biomarkers, right? I mean, tarlatamab's response rate is 40%, so clearly if the DLL3 expression is 80 to 90% in small cell lung cancer, there's something missing there. And so it's some combination probably of the extent of DLL3 expression at the tumor surface, as well as some question of immune cell fitness, right? T-cell exhaustion and things. So I suspect there'll be kind of a two-part biomarker where DLL3 expression and some component of the immune system is important. I don't see anything as an exclusion to tarlatamab, and we've taken those risks and had it play out mostly favorably at MD Anderson. We've given it to patients with active symptomatic brain mets. We've given it to patients with LMD. We've given it to patients that had prior immune-related adverse events, histories of autoimmune diseases, and have not seen really anything emerge from that made us gun-shy about doing it again.
Yeah, I think too, when we talk about tarlatamab, and we'll get into more detail about this too with the dosing and the schedule, but there's a lot of patient buy-in that needs to happen. So hospitalizations and extensive outpatient monitoring, they may not be up for that. And so sometimes that is the exclusion. It's the patient's goals and what they want for treatment and the side effects they're willing to tolerate. So that is something that I see come up as well. But yeah, I haven't seen personally anything with regards to the role of biomarkers quite yet for small cell. Again, just a mystery we're still learning a lot about.
Yeah. I'll add that when we use it off-label, we are checking DLL3 and some of those other neuroendocrine carcinomas. I think it's useful if you're going to argue for off-label use to have some strong rationale. You know, you have a neuroendocrine prostate cancer that's 95% DLL3 positive, then you probably need that data. But I'll stay out of the off-label use discussion here.
All right, so as mentioned, now we're going to kind of jump into monitoring and management of adverse events. Some of this we've probably seen before. It's not necessarily new CRS and ICANS, but we'll go through all of that and kind of the more specifics for tarlatamab. So back to our patient, Peter. So Peter decided to try second-line treatment with tarlatamab, but he's now presenting about 14 hours after his first dose with a fever of 101 Fahrenheit. He also has hypoxia and requiring nasal cannula, and has hypotension, but is responsive to IV fluids. So on to our poll question. So with these symptoms that Peter is having, what do you suspect is going on? And what you suspect it's CRS, and how would you grade it and manage this? So we have option 1, you suspect it's grade 1 CRS. You're going to do symptomatic treatment for fever, consider dexamethasone, and you'll withhold tarlatamab until this resolves, and then resume at the next scheduled dose. Option 2 is grade 2 CRS. You're going to recommend hospitalization, symptomatic treatment for fever, and give supplemental oxygen and IV fluids. Consider dexamethasone and tocilizumab, and withhold tarlatamab and resume at the next dose. Or grade 3, similarly hospitalize, treat the fever, supply oxygen and IV fluids. You're going to consider dexamethasone and toci, but at this point you're going to permanently discontinue tarlatamab. Or 4, you're not sure. All right, so it looks like the majority is believing this is a grade 2, and so we will come back to this and have a little bit more discussion on treatment after we go through some of these slides. So one question we actually had from our virtual audience is, how can the pharmacist be involved in integrating this? And pharmacists play a really crucial role in the treatment and management of patients who have extensive stage small cell lung cancer, or small cell lung cancer in general. One of those things is we can assess the impact of comorbidities and prior toxicities they may have experienced in order to help select the safest and most efficacious treatment for the patient. We also help review all medications and assess for potential drug-drug interactions and try to deal with those head-on. Additionally, we provide education and counseling to patients and caregivers with all new treatments so that they know what to expect and when they should be seeking help. Additionally, we can recommend supportive care interventions to help treat symptoms. And then lastly, we can also help advocate for the patient by submitting insurance appeals if we have any medications that are denied. So really altogether, the pharmacist is a real key player in the patient's essentially treatment journey and helping make sure that we provide safe and coordinated care along with our other oncology team members. So barriers to implementation kind of relates to the question we had earlier on, what are we dealing with? And it seems like everybody's dealing with all of the above. So some issues that we have are site of care. As I mentioned, there's a lot of monitoring with this drug, and not every site is going to be able to support that. Additionally, reimbursement. We'll talk a little bit about an opportunity to help with reimbursement, but it can be a challenge as there is coverage variability, and that can lead to potential delays. Additionally, education. So as I mentioned, not only educating the patient and caregiver, but we also have to educate clinicians. The dosing, administration, toxicity recognition, and early management. What's really crucial is care coordination for these patients. So there has to be really tight-knit communication between the pharmacist, the oncologist, the nurses, your inpatient team that may be monitoring these patients, even your infusion nurses who may be monitoring on the outpatient side. So there needs to be a lot of coordination. And then additionally, we'll talk more about adverse events, focusing more so on CRS and neurotoxicity, but really your institution should have some protocol and trained staff in order to treat these. And so these are all really integral parts in order to implement tarlatamab therapy. So kind of going back to reimbursement, some way that we can help with that is this 2 midnight rule. This midnight rule essentially determines whether we can bill inpatient versus outpatient. So oftentimes when patients are receiving tarlatamab therapy, they will go into an observation encounter. And what this does is it allows the patient to have hospital-level care, but be able to be billed outpatient for reimbursement. This essentially helps reduce hospital costs and appeals. And so per this rule, Medicare Part A will not be used if it's expected to be less than 2 midnights. And that way we are allowed to bill as outpatient, which allows for better reimbursement. So going more into CRS and how we manage this. So CRS is essentially a symptom that can be progressive. It often initially presents as fever, but we may also have symptoms of hypoxia, hypotension, tachycardia, even gastrointestinal toxicities. But this can also be life-threatening. So as mentioned, it is so important for patients to be informed, as well as other clinicians, what to look out for. The patient's going to be presenting to an emergency room. And this can lead to life-threatening complications like cardiac complications, organ damage, lead to neurotoxicity. So very important to be able to recognize these early. And we grade CRS, so grade 1 is going to be more mild and symptomatic treatment, and then it goes all the way to grade 4 where we might have more life-threatening conditions needing ICU care, vasopressor therapy, and respiratory support. But these criteria are really helpful in providing early intervention and making sure that we can treat these patients safely. So there are some strategies that are utilized to try to reduce the risk of CRS. One of those is step-up dosing. So the first dose is a lower dose at 1 milligram. Then for day 8 and 15, it goes up to 10 milligrams, and then the schedule changes to every 2 weeks. On top of that, there is significant monitoring, especially with the first 2 doses. That's the highest risk we see when CRS may present. The typical median time to presentation is about 16 hours after the dose. And so during that time frame, those first 2 doses, patients do need to be, as mentioned, kind of in that observation encounter, so monitored really closely with nursing staff, more on an in-hospital stay, inpatient monitoring, typically for about 24 hours after the dose. Patients also need to be within 1 hour of a hospital setting for 48 hours after the drug's administered. So for those first 2 doses, again, that's mostly because of that CRS risk. Now, the monitoring doesn't necessarily need to be inpatient thereafter, but it is still very significant, and a lot of our outpatient infusion centers might have some difficulty with the length of time patients will need to be monitored. We already have issues with bed availability inpatient and in infusions, so that is another barrier that we're dealing with. Other ways that we try to reduce the risk for CRS, especially with those first 2 doses, is pre-medication with dexamethasone, and we also give a liter of normal saline as well. So these methods are all essentially tried to make sure it's more safer to give this medication and trying to reduce that risk for CRS. One thing I wanted to make sure that was included is how to manage dose delays. This has come up in my practice a few times already, especially we're getting out of the winter months. I've had patients with flu, maybe gastrointestinal toxicities, and we're having to delay treatment, and how does that change the schedule? And so I've had a lot of issues where now the patient needs to be readmitted for starting the step-up dose again. But essentially the concept is fairly simple. So if the gap in treatment has been too long, the patient may need to start the step-up dose again in order to try to reduce that risk of CRS when restarting therapy. So this is available in the package insert, but just know, depending on how long it's been between treatments, you may have to restart that step-up dose. Now, once the patient gets back on track, gets that 10 milligram dose, they're able to go back to their original schedule. So here is the management approach for CRS. This is available in a practice aid as well for you. So I'm not going to go line by line just for the sake of time. But for our grade 1, more mild, these are patients presenting with fever, we're more so going to provide symptomatic management, so an antipyretic. You can consider steroids at this point. But as things progress, or patients are presenting with more grade 2, grade 3, our interventions are going to increase. Patients are going to stay longer inpatient for closer monitoring. We're going to consider steroids like dexamethasone or potentially administered tocilizumab, IV fluids for hypotension, oxygen supplementation for any hypoxia. Depending on if they're having recurrent fevers, maybe you're doing an infectious workup as well, just in case. Getting any imaging for any shortness of breath. And then similarly, the worse things are getting, or if they're presenting more in worse condition, you may need vasopressor therapy, ICU care, and more invasive oxygen supplementation. And the more severe, grade 4, you're likely going to permanently discontinue tarlatamab therapy at that point. So the goal with this is all the same. Essentially, we want to respond early when we see symptoms of CRS, escalate therapy appropriately, and make sure we're keeping patients safe. So the next one we're going to talk about more is ICANS. So ICANS is essentially when our activated immune cells and their cytokines start to affect the brain. And this can present as confusion, seizures, lethargy, somnolence, aphasia, balance issues, and we can even see on imaging some cerebral edema as well. So ICANS can present with T-cell engaging therapies, not only our BiTE therapies, but also CAR T. So this isn't, again, CRS and ICANS are not new to the heme world. They're a little bit newer to us in the solid tumor realm. With ICANS, this can either happen during, before, after CRS, or on its own. So CRS does not necessarily need to be present for someone to experience ICANS. As mentioned, we have those clinical signs. Somnolence is usually the one I see initially, more lethargy, but you can also have confusion, depressed level of consciousness, disorientation, again, seizures as well. And we'll talk a little bit more about some conditions that maybe mimic ICANS but aren't necessarily ICANS. And so we'll talk about scenarios that we have seen in practice. Another tool that's used is the ICE assessment tool, or ICE score. What this includes is assessing a patient's orientation, their ability to name objects, follow commands, writing, and attention. Essentially, the higher the score, the more mild their neurological symptoms are. The lower the score, the more severe. And this all goes into how we grade ICANS. So the ICE score is an incorporation on top of looking at the patient's level of consciousness and any seizure activity, as well as any brain imaging findings as well. And that's all incorporated into our grading. So for our management, again, this is also available in a practice aid, but to kind of briefly talk about the main components. So mild, grade 1, we're going to provide more supportive care. As things start to escalate, they're having more symptoms, higher grade, we're going to provide steroid use, get neurology involved. We're going to have more increased monitoring, more frequent monitoring. We're going to withhold tarlatamab. And as things get more severe, potentially ICU level care, high dose scheduled steroids, and potentially even respiratory support if we feel their airway may be compromised. And so, similar to CRS, the goal here is really early recognition and escalating care appropriately and treating quickly. So here we have medications that are used for CRS and ICANS management. Oftentimes for our bispecifics like tarlatamab, we tend to gravitate more towards steroids as they help dampen that activated immune response we see, as opposed to our IL-6, which is much more specific to IL-6, and we see that used more so in CAR T, though tocilizumab is still an option. We also have siltuximab and anakinra that can be used in more challenging cases. But what's great is we have a range of options here, so we can tailor treatment based on a patient's response. So back to our case. So we have Peter. As mentioned, he's starting tarlatamab therapy. He received his first dose. 14 hours later, he's now presenting with fever. He has some hypoxia requiring nasal cannula and hypotension that is responsive to fluids. So, Dr. Gay, when you see this patient, what are you thinking? I mean, I'm thinking grade 2.
I would agree with you and the audience in the earlier poll. I think this is grade 2.
One question I have is, in grade 2, it's considered dexamethasone. In this case, would you pull the trigger right away? What are you waiting for before you administer dexamethasone?
Yeah, so I would say we actually have probably a low threshold for tocilizumab as well in these, and so we still don't know whether dexamethasone has any negative effects on the benefits of tarlatamab. So we would probably give like a single dose of dexamethasone, and we would have tocilizumab at the ready for this if we didn't see a pretty rapid improvement. This would not trigger us usually to do a more sustained dosing of dexamethasone. Usually we reserve that for either refractory grade 2 or grade 3 CRS.
Yeah, similarly, I feel like in our practice, we'd be quick to pull the trigger on dexamethasone. We aren't using a lot of tocilizumab with tarlatamab, and we've actually been pretty lucky in a sense. We haven't had too much CRS present. I think with the preventative strategies, that's done pretty well for us. But we would likely pull the trigger fairly quickly on using dexamethasone in this instance. Is there any other management that you guys do? I mean, for our practice, if the fever resolves and it doesn't become recurrent, we might not do an infectious workup right away. But if it starts to become more recurrent, we likely would add that in. And get a chest x-ray as well. Is there anything else that you guys may look at in this case and add?
We also are kind of reevaluating the automatic trigger for the infectious disease workup because it seems to extend the hospitalization unnecessarily where people are waiting for the chest x-ray to come back and maybe for 24-hour cultures when we know what caused the fever, right? It's happening at just the timeline that we would expect it to, like in this case, 14 hours after the fact. The likelihood that you're seeing a coincident infection there is very low. So we probably do too much of that and debatably too much tocilizumab here. No other workup unless there's some additional symptom, right? Unless there's neurologic changes or something like that, then we would stop at the infectious disease workup.
Have you had any patients that have needed to delay treatment for symptoms?
We have had patients who, I would say, failed to get out of the hospital between days 1 and day 8 because of complications from day 1 and may have experienced a slight delay. It's the only real time. I mean, once you get past day 8, there's so few side effects that emerge that we haven't really had to delay anyone for symptoms there. We've also had to do some delays because we were trying to mix radiation therapy in for brain metastases or something alongside an urgent tarlatamab start, but I think that's pretty unique.
Yeah, so the cases that I've had more specifically, I had one with influenza, and so we had to delay to allow time for recovery of that, which made us have to do the step up in hospitalizations again. And then additionally, after the first dose, the patient did well, inpatient, was discharged, but when she presented for day 8 in clinic, she was having a lot of gastrointestinal toxicities. She really just was not feeling up for treatment, and so that led again to delays and us having to adjust her treatment again. And so those things have come up, and again, kind of when you see it for the first time, like, oh my gosh, what do I do? How do I make sure that we have a bed in a week and hopefully she's feeling better by then? And so I felt like it was important to bring that up because it is something that I think we're gonna see more the longer patients are on therapy, and especially in those winter months when we're dealing with a lot of RSV and some other infections that just seem to be going around. All right, so we kind of already mentioned this. Patients developed grade 2 ICANS. We talked already more so about the management, but I think one other thing we haven't really talked too much about is maybe comorbid conditions or concurrent medications. Oh, I'm sorry, I'm confused. So now they have grade 2 ICANS, mild somnolence, and awakening only to voice. So with management of this, what are you thinking?
Yeah, so I mean, I agree with the grading of the ICANS. We would start steroids here, certainly start dexamethasone here. We have also pulled the trigger on anti-epileptic drugs pretty early in these patients that exhibit signs of ICANS, though we're currently debating whether that might be overkill. But everything in the first 20 months of tarlatamab has been erring on the side of caution, I think. And then we get an MRI of the brain. We get neuro-oncology involved at this point as well.
In my practice, we have a lot of satellite campuses, and so sometimes our patients are a lot farther from the hospital than we would like. And so we did have a patient present to not our main campus, but one of our satellite campuses into the emergency room. And originally the symptom was I was just more tired, still arousable, but by the time they had made it to the emergency room, completely different story, sending them to the ICU. So I think it's just important that these things can change very rapidly. And as mentioned, not only does our site need to be educated on how to recognize these, but all sites do. Any ED should really have an understanding of what they're looking out for with these drugs. So many times they may see the name. These drugs might not even be on their MAR, so they may not even know what the patient's getting. So those wallet cards are really important, and making sure the patient and caregivers know they need to mention this whenever they present to an ED. Another thing that has come up in my clinic, we had a patient come in who was very somnolent, just really out of it. And the first thing we're thinking is ICANS. But after talking with her a little bit more, it sounded like she had just had a change in her pain regimen, and she had been holding on to some other pain medicine, was adding things in, and basically now the picture changes, and maybe it's more misuse or misunderstanding of pain medications and how to not take same things at the same time in staggered doses, as opposed to more of an ICANS picture. So I think it is really important as a pharmacist to review patients' concomitant medications and seeing, okay, what could also be contributing to what is happening. Another thing that has come up, not necessarily for ICANS, but when I was counseling a patient and talking about CRS, hypotension, do you have blood pressure cuff at home? They mentioned when they smoke, they get hypotensive. Okay, so that's important to know, and it means we kind of have to tailor our education. When do you get hypotensive when you smoke? Is it an all-day thing? When does it resolve? And we have to really tailor that particular patient's education and recognition of symptoms when to call, because at the time, the patient only smokes when they're stressed, but they're about to start a new treatment. They're very stressed. So we talked about smoking cessation. We got him into that clinic, but in the meantime, what do we do? So for that patient, we really had to work as a team to figure out very specific monitoring for him, when he needs to reach out. So I think that's all really important as well. One thing I also wanted to bring up about this case, which we've briefly discussed, but providing home dexamethasone and specific instructions for when patients may take that. Kind of leaning back towards that patient that was presenting to an outside ED and originally at home was maybe just more lethargic, but by the time they get to the ED, things have escalated. Maybe in that patient, when they initially were presenting more somnolent, they call us. If they maybe had done a dexamethasone dose at home and gone to the ED, maybe we could have caught things earlier. So it isn't something that's fully adopted into our practice, and it's kind of hit or miss which patients may get that or not. But we do have a sheet, if patients are going to get a home dexamethasone prescription, what to do. When you have a fever, how long do you wait to take Tylenol? When should you be taking the dexamethasone? When should you be calling? So it's very hit or miss in our practice if that is happening and very provider dependent. And I'm curious kind of in your practice what you guys are doing.
Yes, we don't have any, similarly, I think, we don't have anything completely formal, so it's a little bit provider dependent, but there has been an increasing rate of folks giving this prophylactic, or I guess post-exposure, rather, dexamethasone to take home, and basically with the instructions to like, break the glass if anything seems odd, right? You get a fever, something seems strange, your blood pressure is lower than it usually is, just go ahead and take it, right? Don't risk it. And then if that thing does not improve, come on in and see us or call us. If it does improve, go back to bed and go back to normal.
So I think it's an option and maybe something that will be happening more frequently. This was something that our heme colleagues had been doing with their bispecifics that we were looking into adopting. So not sure if your institutions are doing that, but something to think about. All right, so if you changed your mind based on the poll, you can answer here. We won't go through the results specifically for this, so I'll just give you a second to answer that. Okay, last but not least, how, educating patients and care partners and the important communication pharmacy has in this. So we really need to ensure that patients remain informed and supported through all aspects of treatment. So before treatment, we meet with the patient and their caregiver. We make sure they know the dosing, the schedule. They need to know that they're going to be hospitalized for how long. If something happens while they're hospitalized, you're probably going to have to stay longer. It's not a specific set time. Talking about adverse events, how to manage them, when to recognize them and call us. So all of those things are very important. Again, making sure they know whenever they go to another emergency room or see another doctor, it's a good idea to let them know that they're starting this therapy. During treatment, making sure we're reiterating those side effects, things to look out for and when to seek help. Making sure that we're going over those logistics and scheduling, making sure they understand that even though they went to infusion and they got the drug, they don't just leave right away. So all of those things need to be clearly communicated. And then after treatment, making sure patients have the tools and resources that they need throughout treatment and making sure they know who to call when they have questions and need help. So our last question here, in which of the following areas was today's educational session most helpful to you in guiding your practice related to integration and use of DLL3 targeting T-cell engager therapy in small cell lung cancer treatment? So back to kind of the original question at the beginning. So 1, developing and operationalizing standardized protocols for safe administration and monitoring. 2, multidisciplinary education, collaboration, and coordination of care. 3, diagnosing, grading, and managing CRS and ICANS. 4, overcoming logistical barriers to access and care transitions. 5, dose schedule verification, and patient-specific considerations, or all of the above. To be expected, we can't solve all solutions today, but I think we can all relate to this. Really implementing tarlatamab and BiTE therapies is a challenge, and it takes not just the pharmacist or the oncologist, but a multifaceted, all the stakeholders need to be involved and on the same page. It requires a ton of coordination and education, and so it takes time. I think the biggest thing, from a pharmacy perspective is making sure you have TOSI available, that you're providing education to all the patients that will be involved in the care. So that includes inpatient nurses, what they need to monitor for, even in infusion, how to conduct ICE scores, where should that be located, when to reach out when the scores are low, and who to reach out to. And even in those sessions, providing education to the patient, asking them questions. So I think there's so much that encompasses the use of this drug that it's really hard to find one thing that can solve all of our problems. But hopefully some of this was more helpful, talking about some real world scenarios that we're dealing with and how that may relate to you guys.
We have a few questions. It says here we've got 2 minutes, so we might be able to rapid fire a couple of those. So one question from the audience asks, because the onset of CRS is typically outside the observation time for day 15 and beyond, are we actually adhering to that recommended observation time? If not, how so? And if we are, for why? Obviously, the 6 to 8 hour observation is probably not going to catch a lot of CRS. Are you guys still doing it just to be formal?
Yes, we still are. Just more formality. That was probably honestly one of the biggest challenges we had, because we already are having difficulty getting infusion chairs for patients, potentially with nursing shortages at different times of the year that we had that. And so having a patient take up a chair for the entire day is difficult. And so having to coordinate that, or patients that live an hour away, and doing it more local to them. How comfortable is that team there? Do they have the chair availability as well? So that was a big hurdle for us in our institution, but formally we still are. But I think that's, yes, CRS can still present outside that window, and that's why education is really the key. The caretaker and the patient need to know what to look out for.
We've been telling our patients they can ask to leave, and then the infusion center will call us and we'll grant them permission. So we're not officially telling them that they can leave, but I think one other interesting question that came up from the audience here is that in the case, so Peter had CRS at 14 hours. Had it resolved rapidly, how long do you keep them beyond that? Do you still let them go at 24 hours, or do you add additional time? Do you reset the clock?
To be honest, a lot of that is provider dependent who's on service, if they feel comfortable enough to let them go or not. I feel like typically if a patient's coming in with grade 1 fever, responds well to antipyretics, we're not going to have them stay any additional. But if someone is hypoxic, we really want to monitor, make sure that's starting to resolve. They're able to get off nasal cannula, get to their baseline. In my practice, it's much more provider dependent on how comfortable they are discharging the patient.
We used to do 24 hours fever-free. I think that's become a little bit ridiculous because some of the patients will spike like a once daily fever. And if they were at home, we'd probably just tell them to take Tylenol and keep the Dex handy. So I agree, it's probably overkill and okay to let them go a little bit earlier. But we're still learning. Mm-hmm. I think that puts us at time. There are so many good questions in the chat, but I don't want to keep people. I'm sure they have other things to get onto. Really.
Well, thank you all for joining us. And remember, if your device screen turns green, that will indicate that you have won the gift card, and just head to the back of the room for your gift card. Thank you.